So, good afternoon or good evening, everyone, and thank you for joining us for this African Tea Time session today. It's our very first one this semester, and before anything, I'll introduce myself. My name is Damaris Choti. I work here at Michigan State University as the coordinator for student and alumni programs for the African Studies Center, and Tea Time is one of our signature events that we host monthly now. And this event will be the very first one for this semester. And we have two more that are scheduled for March and April. Uh, so I will drop a link to the African Studies Center website on the chat so you can see the dates and other information for the remaining sessions. We're supposed to have three more, that's February, March, and April. But because of scheduling conflicts, we won't have a tea time in February, but in March and April, we have two schedules. So please, you're always welcome to visit our website at the African Studies Center and to also join us for the African Tea Time and other programs. That's why I feel it's necessary to share the link to the website so you can learn more about what the African Studies Center at Michigan State University does. So today's session, as I believe most of you are aware, we will be talking about the theme of the discussion will be We Too Deserve Empathy, Advancing Mental Health Awareness Through Narrative Change in Frontline and Caring Professions. And our speaker today is Mr. Eliud Akanga. And Mr. Akanga is a Kenyan community development practitioner with over 20 years of experience. His work spans youth mentorship, sustainable development, and mental health advocacy with the expertise in project management and cross-sector stakeholder engagement. And I just want to point out that Mr. Akanga is not new to Michigan State University or the African Studies Center. Previously, he has presented on another topic together with his colleagues, his team that works in many sectors or activities, including youth. And if you went to the African Studies Center and go to our past events, you will see that presentation over there. So we want to thank him for accepting to do this presentation again that is very important on mental health. And as we know, mental health is essential to our ability to function. That's obvious. And I would say that unfortunately in today's world, as we know it or as we experience it, there's a lot of stressors that are from all over. It could be economic, it could be the high unemployment rates in our wherever that we're situated. It could be workloads for those who have employment. It could be political issues that are happening in our current situations, or exposure to other types of traumas that we can't avoid, and much more. But as we know, this has contributed to the illnesses, like many issues, including health and others. And we certainly know that frontline and caregivers or people in those professions are critical in responding to the challenges that we face as the common people or as also people that might be working in those professions. And what that does, it does make them vulnerable. We can all agree that people working in those professions, because of issues that they have to handle, they're very vulnerable to mental health strain. And rarely are their needs discussed or prioritized. And because many times the conversation that we might have or we see researched or talked about is the well-being of those who are being taken care of, the patients, whoever that needs that kind of support that frontline workers and caregivers can provide. So we don't tend to remember their work, and also even to remember that their mental health issues especially need to be prioritized and talked about, and at least so we know how we all can try to support one another, including those who are there to support us. So today's session, I find it very important that we too deserve empathy. And it calls attention to this gap and urges greater empathy and support for frontline workers. And as I said, we are very pleased to welcome Mr. Eliud Akanga, who will share the key findings from the mini study that they did, plus the recommendations, and a little bit about the structure. We are going to allow Eliud to do the presentation. And when he's done, we will have some time for discussion, and I encourage you to have your questions or comments noted somewhere. You are going to have a time after his presentation to ask them verbally or to comment verbally, or you can add those questions on the chat as well. So that's about the long and short introduction of our presenter. Eliud, please, you're welcome to take us through the conversation. Thank you so much, and welcome everybody.
Thank you so much, Dr. Choti, for the very kind words. I'm so humbled. Thank you so much. So good evening, good afternoon, and in some parts, good morning, depending on where you are. I appreciate the diversity of time zones on this call. So we really feel honored, and I feel humbled to be part of this call and also to speak to this diverse audience, global audience. My name is Eliud Akanga, as Dr. Choti said, and I am Kenyan. Kenya is, for the benefit of those who may not know, Kenya is in East Africa, and our capital city is Nairobi. We have a population of 47.6 million. That is as per the 2019 census report. That's when the last census in Kenya was conducted. However, recent UN-based demographic sources indicate that the estimated population for Kenya is 57 million people. So we are a bit many, you can see that. And so thank you so much for joining us. The time zone, our time zone is East African time. And so I can see it's a couple of minutes past 11 p.m. The population I've just mentioned, most of it, the bulk of it is asleep. So that is how the world is moving. So you are so welcome to this, feel so much welcome to this presentation. Feel free to be part of it. It is not a lecture. It's an information session which you can contribute to in one way or another towards the end of the presentation. I work in community development, but enthusiastically, I am a sustainable development professional. Great. So I think we will delve into today's matters. I hope you can all see my screen.
Yes, we can see it.
Great. That sounds good.
Mm-hmm.
Okay. Oh. Good. So now I will do some introduction. I'll start by describing what mental health means. And we have what you can see on the screen. This is a definition by the World Health Organization. And as you know, the World Health Organization is the body, United Nations body that is mandated to promote and monitor, improve health globally. And so we rely on the organization's data and reports for matters relating to health. However, we also have other organizations such as the American Psychological Association, abbreviated as APA, and the Centers for Disease Control and Prevention, which is abbreviated as CDC. These widely, they are the other organizations which are widely recognized and frequently cited on matters health because of their involvement and research. And in doing this mini study, we looked at all these definitions, and we found that there was some synergy, there was an overlapping characteristics in all, the definitions. And this was the issue of coping with the ordinary demands and stresses of life. It was a cross-cutting theme across all the definitions from the three widely recognized and frequently cited organizations. Now, The World Health Organization estimates that 1 in 8 people globally, which is about 12.5%, live with a mental health disorder at any given time in their life. And this report was released in 2022 or 2022 at a time when we were just beginning the post-COVID era. And of course, that era came with a lot of frustration. You know, there were job losses and many other emerging challenges that humanity across the world were encountering. Now, that said and done, with the global WHO, they also estimate the lifetime prevalence, and it is typically higher. It is often cited as 1 in 4 people globally. And the lifetime prevalence refers to the number of people who will experience a mental health condition at any point in their lives. So that number is what is now higher than what the general would be, which is described by the World Health Organization, as you can see. Now, when we get back to the Kenyan context, we had the Kenya Mental Health Task Force report of 2020, and it estimated that 1 in every 4 Kenyans would experience a mental health condition in their lifetime. Now, remember, we are talking about Kenya. So this is what this report said. And this task force was mandated by the Ministry of Health in Kenya. And so it is the ministry that is in charge of health matters in the country, and it gave us this revelation. Now, according to that report, most common conditions were depression, anxiety disorders, and substance use disorders. This was a bit damning because, as we shall see in the subsequent parts of the presentation, it elicited a lot of urge to check into what could be done and what interventions could be done even at small scale, so that we could bring down some of these statistics. Now, in the headlines then, because we are talking about 2022, when this experiment I talk about was conducted, we had a lot of mental health conditions hitting the headlines. So, for example, you can see this was the Star newspaper of May 12th, 2022. And the headline there says, "One policeman kills himself almost every day." And that was a damning statistic. Just thereabout, we had the news. This is Capital FM News, the one on the lower screen, where it shows a crime scene. Okay. Now, we had a policeman who had committed suicide again, and it was becoming so alarming. Thereabout, there were other examples in the news. We even had a psychiatric nurse committing suicide, and she was working in a level 5 hospital, which is a highly ranked hospital in a city called Nyeri. So with all this going around, the issue of mental health started becoming an issue of concern. And that's why we thought as a team that we needed to try and check if there's something we could do. And we realized that these people who were involved in these cases are people who handle frontline duties that appear to be emergency duties. And so we needed to see and hear from them what exactly they were going through to elicit this kind of news. Now, so this is to increase, just to help you understand more about these backgrounds. We also found out that there were barriers to mental health services access, and it was not just affecting the the frontline workers, which we shall describe in the next slide, but it is a common occurrence This is a common occurrence, which apart from Kenya, also affects Africa. So I have been to other African countries, and sometimes when I'm there, I take time to just make a few inquiries. And some of these things, or some of the characteristics of the ideas that are here, are what we found out. So for example, there's the high cost of access to mental health care. That means that mental health care is expensive. It's not affordable, it's costly, and then it's rare. It's rare because because the public health facilities that are readily accessible by the populations in Kenya do not have the service. So it's possible for someone to get other types of healthcare service, but then the mental health is not available. And for that reason, it becomes a bit difficult for the people to gain that access. And so that corroborates the fact that it's expensive, because if it's not available readily, then it means someone has to look for a specialist, and a specialist will be found at a cost, and it will definitely be at a hospital that is more advanced. And then we had underlying stigma. Now, this is to do with the shame. The shame that comes with having a mental health condition. We will find out in our subsequent slides in this presentation how this was affecting these people who work in emergency situations, or the people who work at the front line. Now, stigma is just the fear, okay? For example, there's this notion that people who suffer mental health are mad, which is not true. From our small study, we found that that's not true. And from the definitions that we are getting from the world-known organizations that deal with health, that is also not true. So stigma is one of those barriers or things that prevent people to gain access to medical health, mental health care. And the other one was myths. Remember, when we are talking from Africa, and we have our cultural context, and some of those also mislead. For example, now there's a myth that if someone has a mental health problem, someone is bewitched. So in the field, while in the field, we were able to hear a lot of that. There are people who believe that having a mental health problem is a curse. And so this is not just in Kenya alone, but it's common across the African continent because of the shared cultural beliefs. That was found to be one of the greatest barriers on accessing mental health. And then we had misconceptions. One of the greatest misconceptions is that people describe mental health as the absence of mental illness. And that is not true, because even the latest World Health Organization report, which is on, it's called the 2025 World Mental Health Report by World Health Organization. It emphasizes that the absence of madness, mental illness, does not does not translate to mental wellness. It emphasizes that because it has been a misconception where people, when describing mental wellness, they say it is the absence of mental illness. I would encourage participants to interact with that report, the 2025 Mental Health Report by World Health Organization. It is quite informative with some of these emerging issues. It's not a big document. It's only 296 pages, and it's downloadable on the website. So this list is not exhaustive. The list of the barriers is not exhaustive. We just picked the key items on that based on the mini study we were doing or carrying out. Okay, now we'll go to the adverse effects. We are highlighting the adverse effects. These are the downsides of having poor mental health. And as you can see, anxiety takes the lead, this is excessive fear and just worrying, nervousness or guilt. This is very common. We have mental strain. We also have mental strain, which is of course the stretch that people go through. It leads to interfering. Actually, it's burnout. Burnout describes it better. We have low self-esteem. This is just lack of confidence, and we've seen that. So it happens, and sometimes people get into these conditions unknowingly, and we'll find somewhere else how that is, because mental health conditions are different from the conditions such as injuries which are physical or have pain. We have paranoia. Paranoia is one of the other adverse effects of mental health. This is excessive suspicion and a mistrust of other people. So if you find yourself, very suspicious of other people, something could be happening. It will be good to check what could be it. Accumulated negative emotions is another. And these are just, sadness, perhaps anger, and then they're like low mood and bad mood, despair. Those are negative emotions that again affect us. And then finally, there is a substance addiction. An addiction arises when there's an attempt to cope with the mental health condition, but these are negative coping mechanisms. So with time, it would lead to substance addiction. I will occasionally sip tea now that we are in the African tea time. I hope that goes well with you. Thank you. Great. So having gone through this background, we formed a team that I led, and we wanted to carry out an experiment. It is not a full research. It is an experiment, and as you know, an experiment is carried in a laboratory, and that is a typical experiment. So this is a small-scale study, and which we thought if we have and we can get some findings, it will help us see what next we could do, what interventions could be arrived at, and then a way of contributing to this discourse. So this experiment we conducted in June to July of 2022. It was typically a post-COVID era, and we carried it in Nakuru. Nakuru is the 4th largest city in Kenya, and it is centrally positioned in the country, and very accessible, easily accessible. And we were able to carry the research there, the study there, the experiment, because of the ease of accessing respondents, given the level of resources that we had. And now the experiment was about the plight of frontline workers. Frontline workers are individuals who inspire justice and empathy in times of crisis. Those are the ones we call frontline workers. We have examples. Examples include people like medics, doctors, and anyone in the health sector, because they handle disease. We have rescuers whenever there are disasters, the first line responders, those fall in this category. We have people like the police. We have professions like journalists. Journalists also cover events, for example, in wars where there are, blurry experiences. So that is the category of professions that we were targeting. And we wanted to hear from them what exactly happens to them. And this group is called Frontline Workers, but we gave it the name Narrative Workers. Narrative workers do the work like the one we were doing. They look around and create narratives that help to create change. And that's what we were doing. However, we realized that these people suffer silently. They also suffer mental illness, or they have mental health conditions, but they cannot show it because by virtue of their work, community and society and public assumes that they have the best mechanisms of coping because they are professionals in those fields. It is assumed that they are very well trained. They will not be disturbed by the images they see or the challenges they encounter during their the course of their duties. So we went ahead to check with them, and because of that, we had to call them narrative workers so that there's ownership of this narrative. It is their voice that we wanted to project. We wanted to amplify their voice. And so the message that emerges, we too deserve empathy, is the message from this category of people, these individuals who work in the front line. And so that's why we thought we shall highlight them. But from the study, or from the mini study, we might find perspectives that will help us individuals who are not even in those frontline professions. For example, the people on this call, there could be some who are already working this kind of scenarios, but then there are others who are not in that frontline kind of scenario, but they still go through some of the conditions we are listing here. So again, it becomes something that is helpful to both those within those target group category and those that are outside of the group. And why the plight of frontline workers? When we say they suffer mental conditions silently, then it means they have some distress. They have some levels of distress. They encounter dilemma, and in the process of their work, they also encounter hardship and predicament. So these are the things we're trying to bring out. Damaris, there's someone trying to interfere with the slides. I can see someone trying to check. Yeah, but we will continue nonetheless.
The ones shared?
Yeah, I'm seeing someone trying to draw some lines. Yeah.
Oh, how can they even possibly do that?
Yeah, I think you might need to disable some.
Okay. First, let me. Oh my. Okay,
Yeah,
please continue. Continue. I'll take care of that. Sorry about that.
Yeah, okay. Okay. You can see some image on the screen. The image you see on your screen is one of the promotional messages we used when we were doing our awareness. It talks about testimonies of narrative workers in a film. Okay, you will have access to it, but the key thing is it highlights the experiences of these narrative workers in the face of their traumatic work. So we've seen the kind of work the police do, rescuers, people who save lives, people who are in the front line of war, the kind of experiences they go through. So this film is available. We'll meet it in the next slides, or even at the end of the presentation. The image at the bottom shows a head, someone's head, an individual's head, with what looks like brain, and a cable that is supposed to connect somewhere, but then it's not connected. Okay. And this disconnection is what brings about the distress, the dilemma, the predicament. And so this was just a pictorial, view to try and explain. Sometimes pictures explain more than an individual can do. So we'll go to the next one. Now, this is the methodology. This is the method we used to carry out our experiment. Now, in carrying out our experiment, we utilized 4 methods. So the first one was in-person interviews. The first one was the in-person interviews. So we interviewed individuals in person, physically. And these were professionals in the field, others with lived experience, and others who are, again, just emerging or who have had conditions that we were talking about earlier on, the adverse conditions, the downsides. So we interviewed a consultant psychiatrist, and you all know what a psychiatrist does. We also interviewed an associate professor of psychiatry. This one lectures at a university in School of Medicine and Psychiatry. We had a volunteer community health worker. We had palliative caregiver to a cancer patient. We had a person living with substance use disorder and who was on addiction recovery path. We interviewed a church minister, a certified psychological counselor, and a mortician. So I'll go back so that I take you through the interviews one by one and just pick the highlights of some of the learning we could pick from this mini study. So the consultant psychiatrist, there is context 1 and context 2. What that means is that this was the same person. So he's a lecturer, he's a lecturer, associate professor of psychiatry at a university in Nairobi, in Kenya. Actually, the university is based in Eldoret, one of the other cities of Kenya. And he's also a practicing psychiatrist. So he's a consultant and gets to see patients. So he has all those perspectives as a teacher of psychiatry, which is deep mental health, and then as a consultant who sees patients. Okay. And his experiences were very valuable. He could tell us, he told us, for example, some of the, the myths that interfere with how they work in that profession. For example, he told us that there is a myth that the psychiatrists behave like their patients. Okay, so you remember we said there's this belief that if you have a mental health issue or condition, people think you are mad, which is not the case. Now here, even the people practicing this noble profession are considered to be not normal. Just because they handle people who have mental health conditions, people brand them. Actually, to quote his words, he said, they say, they call us mad. They say, these doctors are just like their patients. So, and it showed the kind of anguish they go through. Like society doesn't understand them, okay? That is one of the experiences. Another one was the uniqueness of mental health conditions. Unlike other physical injuries, or diseases that have symptoms where there's pain and suffering, mental health is different. So someone who has mental health may not be feeling any pain, but it's true that they are not well. Unlike a wound, which is physically, which someone can see. So when mental health issues are being spoken, it becomes very difficult for people to understand because it's not tangible. It's not as tangible as the normal or the usual diseases, common diseases ailments people are used to. Okay. Now, the other one was the community health volunteer. I mentioned earlier that this was the post-COVID period, and of course we were still using masks then. They were just fading away. You know, we had come out of the lockdowns, and this came with job losses. They came with deaths. They came with, you know, loss of lives, losses of lives, and so people were in a traumatic state because things were not working well. So we found a community health worker who was helping young girls to get back to their course, because during the lockdown, remember, schools, colleges were closed, everywhere was closed. And so when the lockdowns were getting, were ending and life was coming back to normal, there was a lot of anguish, you know, among parents, guardians, the government. We had a lot of pregnancies in Kenya because of people having been idle and also predators having, you know, waylaid girls. And so this community health worker was helping girls to get back to their track by, you know, training them on life skills and just giving them hope that all is not gone. And then she had opened, she had started an organization, and this organization was training the girls on tailoring skills so that they could get skills and then they could use that for self-employment. Now, in the process of her work, she also encountered a lot of challenges. It was overwhelming. There were no funds, there were no resources, but she still needed to help. And so again, she underwent the same traumatic experience that she was trying to cure. And so she shared that and how overwhelming it was and how society was also perceiving her cause, her initiative. The other interview we contacted was the palliative caregiver to a cancer patient. Cancer is devastating, and unfortunately, this was also the spouse to this interviewee. And so it was very traumatizing for her that she could go through that kind of stuff. Now, it made her indulge in substance use because of the pain. I mean, she could see the pain the spouse was going through. It was unbearable. She could do nothing. And she was also feeling like she's losing a loved one. And because of that, she indulged slowly into substances, drugs, and with the hope that this would help soothe her challenges, her mental issues. But it didn't work. Instead, she slipped into addiction. And she slipped into addiction for 28 years. 28 years is not, those are 2 decades, close to 3 decades. Okay. And so that was very tough. She gave us lived experiences. And because of that addiction and the challenges she went through, on her recovery, she decided to start an organization that supports people who need services such as drug addiction recovery, rehabilitation, and the like. So those struggling with addiction, she's able to support them. And it's through that that she was also getting her therapy, from her explanation. So here I put it, she's a person living with substance use disorder. So she's recovering from addiction, but to enhance her therapy, she is also supporting those who are like in a worse state. And she's been there for 28 years. She has a story to tell. Then it makes it easier for her to help those who are struggling, because her lived experiences can be used as a study. They can be used as a way of helping the other generations to get back to their normal lives. Okay, so in her own words, she described that as like having gone to hell and back. Quite a chilling experience. I will pause at this point and stop sharing so that I ask Damaris to play a video, which is just a 1-minute video. We will interact with it, and then we get back to our presentation again. Damaris.
So, Eliud, do you want me to play the three of them together, like one at a time?
No, you'll play the first one first. The first one only.
One first. Okay, sounds good. If you can share your screen, please.
Oh, shortly. Okay.
All right. Let's see. I believe this is the first one. Share with sound and can you see the screen before I play?
Yes.
Good.
Yes.
Yeah, yes, we can see it.
Sounds good. So I'm gonna, hello.
Yeah, go ahead.
Let's see, okay, good. I was trying to.
Silence with no help.
I'll
That's
start
why
over, sorry.
volunteering.
Okay.
Let the community understand what you're undergoing. Many people think that I'm after money. I'm not after money. I've gone to hell and back. For me to do this, it's because of what I've undergone. Being in drug addiction for 28 years, I've seen a lot. And I wouldn't like anybody to undergo what I've gone through, especially women, female, because it's not a place to be. And when I see somebody suffering, I remember those days that I suffered in silence with no help. That's why I volunteer doing this work with all the passion and all my might, sacrificing my time and resources. So if I can get the community to back up what we do, maybe I'll have an impact to the community. Because right now, people don't really understand what I do. But if they open up and let me explain, it will be in a better position, not only to me, to all the caregivers around the nation.
Thank you.
Yeah, I'm sorry, the sound is quite low. Don't know if there's anything I would have done to make it higher, but I hope people understood it. Do I stop sharing?
Yeah, you can stop sharing. Yeah, so well, the sound was a bit low, but I'll try and recap what the lady was saying. Some of you might have heard what she said. She was talking about having been in addiction for 28 years, and she decided to start the organization where she's helping people, not because she is looking for money, the way other people think, the way society thinks, but so that no one else goes through what she went through. She wouldn't want to see other people, and she mentioned specifically female, the ladies. She wouldn't want to see another female like her go through what she went through. It was so harrowing. And then she's appealing for people to just understand and give them an ear, because they're out to help, but being a person who's recovering from addiction, there's a tendency to brush her off. So that is in summary what she was trying to talk about. Now I'll go to the other interviewee, who was the church minister with Context 1 and certified psychological counselor Context 2. That is the same person who is trained, is a certified psychological counselor, meaning he is a service provider to mental health care, and is also a church minister, a reverend in a church. And so he said he's trusted, congregants trust him, they find him reliable. Actually, he combines, he integrates professional counseling with faith-based therapy, which helps him, easily help people who have mental health conditions. But he says, even in doing all this, people are so reliant on you because they know you help them, handle their conditions and issues. But when it comes to him, people tend to back off because they think, he's the expert. He can handle it. He doesn't need us. And he shared an episode where he lost a loved one. And he found it so difficult to cope because when he broke down, there was nobody to support him. Even the church thinks, I mean, our reverend is okay. He's even our intercessor between us and God. So he should be able to do that. The clients think, I mean, he's super trained, certified. He can manage himself. So he says that was a very difficult moment for him. And that just, corroborates and, shows, it confirms the misconception that, you have to be strong. I mean, you are expert, so you can handle yourself. But the truth is, these people are just these individuals, and these professionals handle these things, in silence. Now they have no one to tell that, yes, I'm an expert, but on this one, I cannot. And so these are the misconceptions that this narrative sought to change. We will go to the mortician. The mortician is a person who works at the mortuary. And some of their duties involve, they include, embalming bodies, taking care of bodies, and, in other jurisdictions, they are called undertakers. Now, in Africa, death is terrifying. Death is dreaded, and actually it is even intimidating. So let alone the person who takes care of dead people. Death itself is dreaded, and the person who takes care of the dead people is even more dreaded. We got the chance to interview this gentleman, and he gave us his accounts. And again, as expected, because of the fear people have about death, he doesn't have friends. Friends keep off because of his profession. Okay. In fact, he said it is so difficult to date because you get a partner, you are dating, you meet once, and when they ask, so where do you work? And then you say, I work at the morgue, I'm the manager there, or I'm the supervisor there. People take off. So you can see, and then now it leaves him again traumatized. Now I'm just a normal person. How could this happen? And so the appeal was, we are normal people. We are normal people. This is a profession. Treat it like any other profession, like an office, because that is my office. And in any case, if someone dies, there still has to be someone to take care of them. So that work has to be there, and it has to be done. That was his appeal. And he had these sort of traumatizing moments, because you would imagine he's so used to handling dead people, therefore he is strong. But this is what he said. One of the most devastating moments was when his colleague that was working with him at the same morgue died, and now it was his turn to take care of his body. So he said that, that broke him. He couldn't manage it. You will see it in subsequent videos, which we will share later. And so that was the most difficult moment. Now you see, you fear somebody thinking they are an undertaker, so nothing can cross them. But you see, they are here broken when they see their colleague is now dead and they have to take care of him. So I'll stop sharing and ask Dr. Choti again to share the next video.
They hear someone is working in a mortuary, they should think like someone working somewhere else in an office. We are not different, and that mentality of them that we take something like something to make us high, it is not good mentality. The community have to understand that even if a person dies, needs our care, and there must be a person who will take care for those people. So when they hear someone is working in a mortuary, they should think like someone working somewhere else in an office. We are not different, and that mentality of them that we take something like something to make us high, it is not good mentality. The community have to understand that even if a person dies, needs our care, and there must be a person who will take care for those people. So when they hear someone is working in a mortuary, they should think like someone working somewhere else in an office. We are not different, and that mentality of them that we take something like something to make us high, it is not good mentality.
Thank you. Yeah, you heard it. The mentality is not good, that they have to take something for them to work. Something means maybe substances to try and camouflage their feelings. But he's simply saying, we are normal human beings, we also have feelings. So what you feel, you who works in an office, in a government office, the things you go through are the same things I go through, okay? So that is one of the revelations we found. So we will go to the next category. Can you see my screen? I hope.
We can.
Okay.
It's shared. Thank you.
It's shared, okay. It can't move. I don't know what is the problem.
It's not moving.
Yeah.
We can see it.
Okay.
Maybe you can share and share again.
Yeah, I'll stop sharing. I'll share again.
Yeah.
Okay.
That's fine. It's not?
Oh. Yeah, not yet.
Okay, do you want me to share mine?
Yeah, you can share yours. We can move together. I'll stop sharing.
Okay, sure. You can tell me when to.
Yeah.
I'm hoping that mine will. This is the one. I'll share and go to. Give me a second here.
Slide 11.
Okay. Is it shared?
Yes. Yeah, it's sharing.
And then I can go next.
Yeah, if you can do presenter mode, that would be fine.
Presenter mode. Sorry. Give me a second. I have on top here slideshow.
Well, while Dr. Choti is doing that, I have not very good news. That gentleman you just saw, the one who was working at the morgue, we lost him a couple of months ago through a road crash, a car crash. And he was just coming from work. He was headed home in the hospital van, and they were knocked, and a couple of them, I think 4 of them died on the spot, just near their gate. So it's devastating. After having had his episode, you can imagine how that feels.
Oh my gosh. Sorry about that. That's just sad.
Yeah. Okay. Yeah. Great.
So is it are we on the that's screen talk? So that's give me a second. So this is it a screen?
Let's go to 12.
So is it shared properly though?
Now 12.
No, I'm saying, is it showing properly on your end? The slideshow?
Yes, it is. Yeah, it is.
It
is. I don't know about the other participants. Someone could confirm.
Please let us know if you can see the screen that I shared.
Yes, we can. Like me, I can.
Okay, thank you so much.
Yeah, brilliant. Now, the other method was we used to capture this study was through a community radio broadcast in the city of Nakuru, as I said. This community radio covers a radius of 100 kilometers approximately, which is again 62 miles if you use the imperial units. And we targeted a live morning rush hour radio show because in Kenya, there is a culture of the popular morning shows when people are rushing to work. They listen to radio in their personal vehicles and even in public vehicles. So the idea was to get to those, the audience that the station reaches, so that we could, propagate this message further. And so one of our team members was the guest that morning. The show ran for an hour, and it was a call-in session. People would ask questions and get clarity. And the theme was depression in men and narrative workers. And it was also, based on the aftermath of the COVID pandemic. So listeners participated, they asked questions, they got clarifications, and the issue of people misunderstanding what the narrative workers go through was explained well, because the guest team member Agatha will find their names later, is a professional psychological counselor and also a trainer. So she was able to articulate this well, and we reached quite a number of people. The other method was we used tweet chats sessions, 3 of them, and each lasted an hour of live session and an hour of retweeting. Now, how this works is we sought the services of bloggers. Ordinarily, they are called bloggers, but their deal name is influencers. They have influence because of their their wide network of followers on social media. And on this one, we're using Twitter. I'm saying Twitter because it hadn't rebranded to the current X. As at the time of this experiment in 2022, it hadn't rebranded to X. And so the tweet chat sessions are hosted. You have questions, you have topics, and so they are led by these influencers. So once, as the discussions are going on, they are retweeting, and because they have so many followers, some retweet, some also give counter questions, some give rejoinders, and the message goes viral. So the idea was to create that virality, so that this message of frontline workers, that they deserve empathy, could go as far as possible. And that's why we called it #WeTooDeserveEmpathy. It also had its own outcomes, which we shall see in the next slide. And the final method was Zoom. We had a Zoom discussion, which was live streamed on Facebook platform, and the discussion was on mental health awareness among frontline workers, the case of Kenyan police. We invited the senior-most head of counseling at the Kenya Police Service. He was with us for an hour discussing on the challenges they were going through. Remember our headlines in the earlier slides, where we found the police service was having challenges with the officers committing suicide. So we thought that would be a good place to start and just find what exactly is happening. And so we had officers, junior officers there, we had mid-level officers, and the public participating in this Zoom call that was streaming live on Facebook. We could go to the next one, Damaris.
Okay.
Yeah. So the idea of leveraging the followership of bloggers and influencers is that when these messages are retweeted, we wanted it to go as far as possible. We are trying to create awareness. So, as they share the posters, as they share the questions, more and more people get to see it and get to hear. We already had radio, we had interviews, which we put on YouTube and things like that. Now, next there's that image, which simply indicates the care, okay? The care we need to take. That is a picture of a brain and being embraced by hands, okay? It's a message that we need to take care of our mental wellness. And if you look at that image, it's green. That green is a theme. It's a theme that resonates with mental health, and it implies healing. It implies balance. It implies renewal. It also implies calm, because these are the core goals that mental well-being stands for. And so the hands are simply supporting so that we're able to take care of our brains, minds and health, mental health very, very, very well. Let's go to the next one. Yes, this is an image that we used in one of the tweet chats. I decided to share it so that you could see what happens. You can see it has a date. This was on 28th of June, 2022. It also has a picture of someone and showing the mental, something is happening in their mental space. And so it was, you can see the theme is also green there, and it's part of, creating the awareness. You can see the hashtag, we too deserve empathy. And so these are what we use to propagate and create virality so that this message could reach as many people as possible. We can go to the next. Now, the next slide shows the output summary, a summary of these methods that we use to reach people. So I'll go straight to the table so that I can move a little bit faster. The live radio talk show, we already saw that it was held in Kiswahili. And Kiswahili is one of the two national languages in Kenya, the other one being English. Kiswahili is more spoken than English, and even more understood by many Kenyans. Actually, it is estimated that 90% of Kenyans can speak in Kiswahili. So the talk show was deliberate so that as many people as possible can understand it. And as we said, its coverage is about 100 kilometers, which translates to 62 miles. And the estimated reach is 500,000 listeners per program. And that is the self-disclosure we got from the station. Okay. We were yet to
kuingia katika mazungumzo nilikuahidi kwamba tutaangalia leo msongo wa mawazo, depression, stress na masuala mengine kama yale, na nimekuambia leo tutakuwa tunaangazia kwa upande wa wanaume.
I think you click.
Wanaume wako na majukumu mengi sana.
Did someone click it?
Mtaalamu wetu aweze kutupatia uondo.
No, I think my
Jema sana niko.
Habari ya siku mingi kwanza.
sorry.
Salama.
No, it's my
You did click it by
mouse that
mistake.
hang. Yeah. Sorry though, but let's go back. Am I
Okay.
still shared?
I can't see it.
Let me stop
Yeah, but I
sharing
can
and go back.
continue speaking, nonetheless. Yeah, so the talk show was, I was explaining that it was in Kiswahili to ensure that it reaches as many people as possible. And we saw that the self-disclosure of the station was that, yes, there we go. They reach at least 500,000 per program.
Oh,
Yeah, so it's good, Damaris, it's okay.
okay.
Yeah.
I see what happened. Sorry.
Yeah, so in the comments, those are the links. Actually, they are live. If you click them, we will share them with the after the presentation. That is the comment. I mean, in the comment section, you see those links. That is the link to the radio program, and then we have another product that we got from this output was a 35-minute YouTube documentary. This one had 500 views. Perhaps that has changed, and I'm sure when you go back there and hit it, it will get to more. The 3 Twitter chat sessions, remember I said Twitter because it had not rebranded to X, was at 30,000, and that was then. So we want to believe that post the session, if there have been other resharings, that could have gone further, and the links are available. I did not share them here because there are so many and very long, but they are there. The Zoom discussion, the live session, at the live session, we were interacting with 150 people. And during the session, we appealed that those who were there could share with at least 10 people, 10 friends of theirs on Facebook. So the projected resharing was at 1,500 post-session. Okay, we can go to the next slide. Now, the other output is an anthology. An anthology is a short story. So this anthology, we published it on a platform that shares stories that propagate narratives, that change society and create change. So it is available also online. The platform is called Doing Things with Stories. So this one was under the category of narrative change practice story, and it was published in 2022. Yes, it was published in 2022. It's available. You can interact with it. These are just ways of propagating this, making it go viral, making it reach as many people as possible. Part of the amplification. We could go to the next slide. Thank you. So what did we expect? What did you anticipate? We wanted to break the silence of these frontline workers. FW means frontline workers. So we wanted to break their silence. We said that, remember we said earlier, these people suffer, these individuals, suffer in silence. And we wanted to break that silence so that their voice is heard. They need empathy and they need kindness. Just as they promote it, they also need it. And then we wanted to highlight their stoicism. Stoicism is that hidden bravery where someone would appear very okay, but they are suffering inside. I'll try and contextualize this in African families. Say a family head, a father, maybe a husband or a single parent has children, and he has to fend for them, he has to provide for them, but he's undergoing difficulties in getting resources or there are other challenges. However, he looks very strong. It looks like everything is fine because he doesn't want to break down. And then the children will say, now if the person we depend on is breaking down, it means we are done. So they'll put on a brave face. It's just disguised bravery, but actually they are suffering. So we wanted to highlight this among these frontline workers. And thirdly, to raise public awareness on the significance of offering moral support. Okay, we raise awareness so that once people are aware, can they act? Is there something people can do? Let's move to the next one. Okay. What we found. There was what we expected and what we found. Now, findings suggest that public and society has limited awareness of the mental agony endured by these, frontline workers, the narrative workers, and particularly in times of stress or distress. Okay, so that is when they are most. That's when they most need, support, moral support, but the public doesn't give it because of lack of awareness. We also found that there is clear need to empathize with these people. There's clear need to empathize with these people because from their lived experiences, they were appealing for society to understand them, okay? So that they are able to work better, to work better to those that need the service. And even those they serve should also understand them. This appeal was very clear. We've had it in the video, and there are more videos which you will interact with later. And these were the two great outcomes from that mini study. We could go to the next one. Great. So recommendations. The experiment recommended that the frontline workers need some extension of empathy and moral support, because as they work to promote acts of kindness and justice, they really need this support so that because this would strengthen their emotional foundations, so that when they are in the quest of supporting or promoting kindness, they are not empty. they have some strength. It's like their cups are empty, so they need to be refilled over and over so that they can remain strong. The strength that society assumes they have, it actually needs to be, revitalized. And they also need to be encouraged. That is the second bullet, propagating narrative that demystifies misconceptions. That means let us give them uplifting stories instead of spreading words that bring them down. Instead of saying psychiatrists are like their patients, we need to propagate. We need to remove those, to change narrative of misconceptions. We can support. We can do something. That is one of the recommendations that was very key. For example, there's this other one who began an organization that is supporting people struggling with addiction. And yet there are members of society who say, this one is just out to look for money. That is not moral support. Now, we need to counter that narrative. On the third bullet, we need to offer them genuine appreciation because they are dedicated, they do their work diligently. Even verbal appreciation, it could be, you could send a note, you could send a text, you could even hug somebody. That goes a long way in helping somebody emotionally, and especially these frontline workers. They said it themselves, they have an account of their lived experiences, and that would really be helpful to them. And finally, you listen to them actively. That means that we don't judge them. When they have their frustrations, we need to support them. We need to support them because it is then that now they have a basis for supporting others that need the services. So we'll play the final video. I'll stop sharing and Damaris will play the final video.
Actually, I'm the one sharing, so let's try and see if this works.
Play it. Sorry.
Let me see if this is gonna work for me. No? Okay, I'll stop sharing and to the original video.
Okay.
And share it. And I believe this is the one.
And so it's important that we invest time and resources in taking care of our mental health at all times. Thank you. Our parting shot is to remind people who will be listening to me now and in the future that there will never be health without mental health. So unless we take care of your mental health, your physical health will never be complete, your social health will never be complete. And so it's important that we invest time and resources in taking care of our mental health at all times. Thank you.
All right, I'll stop sharing.
Thank you. Thank you. Now, that message is meant for you who is on this call. Forget about the frontline workers. We have made recommendations, but this message is for you. I hope you heard the professor of psychiatry say that you have to invest in mental health, because if it's not well, then you are not okay. The other health that you work very hard to maintain might just be going to waste. There's still a few slides, Damaris.
Okay, you want me to share this? Okay, I'll do that.
Yeah. The last about 2 or 3.
Oh my, I know. So let's see what this is.
Yeah.
So you can continue talking, please.
Yeah. So whereas this experiment is about highlighting the plight of frontline workers, the narrative workers, the ideal situation is that we are all vulnerable. We are all vulnerable. Remember the 1 in 4 statistic. 1 person in 4 in Kenya, they suffer mental health at one point in their life. So if you are 4 in a room, one of you, especially if you're in Kenya and you are 4 in a room, one of you, I know people are counting and saying it's not me. It's very easy to say it's the other person. But the reality is that we are all vulnerable, and this happens to all of us. Even the simplest of things, you'll go back a bit. Even the simplest of things have led to mental health conditions. For example, those who love sports, when their teams lose, I mean, it changes their mood. They become anxious, and we already saw those characteristics. So they are not just for they're not just for the frontline workers, but we are all vulnerable. Has it disappeared?
No. Let's see if this is the right one, and then I can go to the
Okay.
To the very end. Okay, slideshow. Let's say even from the current book. Oh my gosh. I don't know. I think this going back and forth is tampering with things, but
Okay.
This
just go go to 2020. Yes, 20 is the next one.
Okay, let's see if from current slide would work now. Okay.
Okay.
Hope it's shared.
We're done with now share the next one, which is 20. Yes, what next?
Okay. Behind? Is it this?
Yeah. Back again.
Like one more.
Again.
Okay.
That one. So now we are done with the experiment. So what next? I know that question would come up. Let me attempt to answer it, just in case it will. Our idea is to scale up this experiment initiative into a full research, because as I mentioned, this is not a research. If you look at the sample size, it's very small. So it's basically looks like a lab experiment where you just you scoop a little chemical and put in some liquid and solution is found. So our thinking and our forecast is that this could be scaled up into a full research, because if that happens, then we can have concrete data and findings that can give recommendations that are applicable or in practice. Okay, because we really need this and to support this discourse, the fact that World Health Organization acknowledges in their recent report that I encourage people to read, that the need for mental health services is huge, but the response is inadequate completely. So with this kind of messaging and initiatives, if we can get more, delve further into research, this would really be helpful. And then exploring the capacity building mechanisms for initiatives. Here, a good example is the lady who established an organization that is supporting people struggling with addiction. She's doing it based on the lived experiences. So she needs to be capacity built, in terms of how to run organization, on how to, on things like nutrition and counseling, psychosocial support and things like that. And then we need enhanced knowledge sharing and exchange programs. That is self-explanatory. Of course, learning from best practices. And one of the things we were thinking is mental health issues or terms are basically in English. The best that can be done is to translate them into Kiswahili. But if we have this knowledge shared in languages that can be understood at local level, vernacular languages, native languages, that would be one of the ways to help enhance, how people understand mental health issues. We can go to the next. Now, this is the team that worked on this. We had Agatha Mumo. Agatha is a psychologist, is a psychology counselor, and she's a founder of Acadian Counseling Center, which is based in Nakuru City. Zipporah Nyagara, and I think she's on the call. She will have to say hi. Is also a psychological counselor and trainer, also founder of Haven of Dreams. Mr. David Omulando is a statistician and is also an information and knowledge science management scientist. And we had Kennedy Amungo. This was a professional corporate photographer. As you can see, the team was interdisciplinary, and this was to enhance knowledge sharing and just creating a learning from the best, something like that. Okay. We were able to leverage each one's expertise so that we could come up with the best experiment. And their methods were very intriguing. They are very good and very helpful. So we really appreciate them. Once I'm done with the presentation, if there are any on the call, they'll have to say something briefly before we go to the questions session. Let's go to the next. Okay, the next set of acknowledgements is the Funders Initiative for Civil Society, who provided the grant that supported the initiative. All our respondents, the Kenya mainstream media houses and journalists that we interacted with, the head of counseling at the Kenya Police Service, the Twitter influencers that we used, the general public, and of course, the African Studies Center of Michigan State University for giving us this platform again to create another virality. So thank you very much for that, Damaris. Please extend our appreciation to your team and the university at large for this opportunity. And with that, we are done with today's presentation. That is my contact. That is how I look when I'm not very sad. So when the mental wellness is okay, and those are my contacts, we can interact. You saw one of the projections was about scaling that up to research. If there's anyone on the call who is interested and who feels that this topic, this discipline excites them and their networks, please get in touch and we can see how to bring that to speed so that we can propagate it further. So thank you very much for listening to me. I will ask Zipporah, David, Agatha, if they're on the call, you can say hi to the audience, and then we can hand it over before we hand it over to Damaris. You may unmute.
Okay, Amigo. Hello, everyone. Thank you so much, Eliud, for the presentation. That was very well presented. Very great memories as well for all the work that we put in and all the learnings that we got, the experiences as well. Of course, mental health being a very key aspect of our lives these days. So much importance to create the awareness. So nice to also meet everyone. So thank you once again. I'm David.
Thank you.
Thank you, David. Somebody else, Eliud, that is on the call that you want to?
Is Zipporah there? Okay, if she's not, we can.
Okay, she's there. Maybe she's preparing to contribute, but Zipporah, whenever you're ready, you can let us know. But I sincerely want to thank you, Eliud, for taking us through this presentation. Sometimes it's tough. It's really tough to even sit and listen. And as you said, frontline workers plus caregivers, if we're sitting here and listening, and sometimes it becomes tough to participate in by listening. How is it for those who offer those services? So this work, as you said, it's work that really needs to be scaled up as much as possible. And thanks for sharing your time and the study as well on this platform. I know it's late and sometimes we don't seem to have many people in the presentation, but believe me, when it's shared on our YouTube channel, there's engagement. So that's why we feel good to have this recorded, because the time doesn't allow for everybody that would have loved to be here. So thank you so much. I don't want to even ask a question. We have people here that have sent their questions, and I know perhaps there are more that would want to unmute and speak. So I would keep my questions. You've heard my voice enough, and go and start with the very first question that was on the chat. I think my mouse is misbehaving so much today for some reason. My cursor the same. But I would start with Amani's question. Amani asks, why are mental health cases continuing to rise even with the availability of numerous approaches and solutions aimed at improving mental well-being? That's for you, Eliud.
Yeah, my quick response to, thank you, Amani, for this question. My quick response to that would be what I covered based on the latest WHO report on mental health. It acknowledges that the needs exceed the response. So as much as there are interventions, they are not up to speed with the rise. And you can see if, for example, where you come from, I don't know whether Amani Mwacha is Kenyan, but if you are Kenyan, your nearest sub-county hospital or your nearest dispensary or private hospital, does it have a mental health professional? The most likely answer is no. So it means you have to go further to the next level of hospital. And if there isn't, you have to go to a referral hospital to get mental health services. So, the further you go, the trail you leave behind means those people, that population is not covered. So definitely the cases would rise. Thank you.
Thank you, Eliud. I hope, Amani, you've had the response, and thanks for responding, Eliud. And then we have Seth, who is saying, how come mental health disorders become prevalent? I think it's the same question, pretty much.
Yes.
Have become more prevalent this year than before. So I'm hoping that, Seth, unless you have a follow-up, the question has been responded to.
Maybe I'll add something as much as it's the same, because Amani's was about the rise. And this one vis-a-vis the approaches. So I think the one for Seth is the first answer. I think his has two answers. The first one is the one I've given, and I would also say the rise also in the use of substances could also be attributed to that from the readings we encounter, and that's why we really need research so that we can now unravel this properly so that it is addressed in the appropriate manner. There's a hand from David.
Yes, I see David. Please go ahead, David. You can unmute yourself. Thank you.
Oh, okay. Thank you. Yeah. So just on the same questions, looking at it statistically or from a data point of view, also awareness being raised on mental health issues, we would also expect more diagnosis, for example. So you would notice in the data that there would be an increase in the cases. So yes, there has been an increase, but we can also acknowledge that with more awareness, with more outreach, these frontline workers reaching out to communities, some marginalized communities, and having people opening up and even going through or being diagnosed with mental health issues, then the data sort of spirals. So that's just what I wanted to add to what Eliud had mentioned. Thank you.
Thank you.
Thank you, David.
Yeah, creating the awareness or continuing to spread the word is important.
Yeah, sure.
I mean, that's why we're here.
That's why we are here. Meanwhile, I've shared a link in the chat. That is the link to the video that was that was created. It's on YouTube. You can it's a 35-minute video. 35 minutes is not so long. You can interact with it at your own time. I will also share the radio, the link to the radio program. You can also interact with it. I will do that shortly. But if there's another question, please, you could shoot it.
Yeah, I see we're 2 minutes after time. If you can allow us a little bit in case somebody else has a comment or a question before we wrap it up. Please feel free to.
Hello.
Yes, Margaret.
Yeah, I'm trying to find the hand and the hand is not, I don't know where it went.
It's okay. It's technology. Don't worry about it. Just go ahead.
Sorry. I can't even put on my video because I'm in bed.
It's okay.
So my name is Margaret. I'm based in Johannesburg. And it's amazing because I worked with Eliud for quite a while. I mean, when I was in Kenya and we worked in the community. So it's just great to see that they continue that work, and that, I mean, now this is just amazing because, mental health is one of those things. I mean, it's a big deal, and especially after COVID. So I'm looking at, you are thinking about scaling, but I was just, as a researcher, I was just thinking about the methodology. Maybe that's where I was having like questions, because you had this, in terms of power dynamics, you have a professor and then you have a mortician. Then how do the opinions provided from these extremes of people, how do you balance it in terms of, making analysis? Maybe that is a very academic question, which you are not, wasn't the intention of the study. You don't have to answer that. But what I would have really loved to hear is this. Sometimes when you interview these people who have mental issues or are going through, you might end up re-traumatizing them. So I don't know how you navigated that.
Oh, thank you. Thank you for that. Now, that's why in our team, we had 2 psychological counselors, certified ones, and they're also trainers. So they train counseling psychologists and they are psychologists themselves so that they could approach it in the best professional manner they could. And that's where now I would stand aside and let them do that. And just with the photographer, they handle them. And that's how we were able to capture. And if you might want to realize, most of these contacts are the people they've interacted with in the course of their professions or in their trainings. And that's how there are people they've worked with also before in other spaces. So it was very easy for them to blend and get authentic responses. I hope that answers.
Yeah, I think.
Yes, it does. Thank you.
I can add something little about the question, Margaret, that you had about the dynamics in terms of the respondents. I think I love the idea that you call these, what did you call them? Narrative workers.
Yeah.
Because when you're sharing a narrative or when you're part of a research that allow you to share your experience, I believe that you own the story. It's you. So I would think the way you framed it in itself helps to, respond, I believe, to Margaret's question, like how would you analyze? Because a story, there's no 2 ways of understanding a story. If it's my story, if it's my experience, it has to stay. That's what it is. There's no way to change it. So I believe framing it like it's the narratives and voices that are being amplified. It's somebody sharing their own experience, just solves the math problems, because there's no other way. Whether you're a professor, whether you are whoever you are, what is your experience still remains to be your experience. So not to say, Margaret, that that's not a valid question, but I just really love the way it's been framed for the purpose of this study. So thank you, and thank you for your question, Margaret, as well. Any more comment or question
Maybe,
before?
yeah, I would add to that also for Margaret. That's why I gave a disclaimer that it wasn't a research per se. It was an experiment. And you realize the other product that came out of it was an anthology, a published short story. So it's actually a storytelling approach, which wouldn't work for research, proper research that requires, that kind of style. So it was basically people saying, people giving their own lived experiences. And because we are interviewing them and doing the narrative, we don't want to own. We called them narrative workers so that the narrative that comes out is actually coming from them. When they say we to deserve empathy, it is not Eliud, it's not Agatha saying, it is them. Thanks.
Okay, thank you.
Thank you so much. Any more comments, questions? We don't want to close anybody out.
Dr. Choti, Gishuki here.
Yes.
I'm not in bed. I'm in the sitting room.
Okay.
like Margaret, my good friend from South Africa. Hi, Margaret.
Hi.
Great. Thanks, Eliud, for sharing and just that elaborate. It reminded me of my neighbor in Kisumu, who is also a mortician.
Oh,
and we really take a lot of stories. We really talk stories, and those storytelling really are very good medicine for the healing process, because end of the day is about the healing process, and the wounds they carry along, what they see, the experience they go through, and how that also come to affect their family setups. And I think that interaction for me I've had with this great friend of mine, it is how much he opens up to share the stories of what's happening. And sometimes he'll tell you, what happened, and, a certain moment, and what the community said, what someone said, But what I found out was the fact that this person had accepted the reality of his work. And I think that's the same story. I think the friend from Nakuru who passed on also shared the same, accepting and moving on. So I think in one of the way of moving forward, in one of your recommendations, I think next steps is to find what strategies do we put in place as trainers, as community development workers who have this specialty area to support those people who are not reached, and rarely do they get people who understand them in the whole process, to give them that environment where they can actually share their story. So I'll be looking at that more into the future for the purpose of supporting them. And I'm sure there are many others that were not mentioned here that would be very, very key to our own environment. And sometimes even where in schools, for example, you find in a school environment where there are people who are not part of the teachers, and they're called non-teaching staff. And there's so much happening in that school, and these people are always behind the scene, but they never come out to really share. So categorization could be useful in the future because they're frontline workers. When they're celebrating the results of exams, these people are never mentioned anywhere. The mpishi huko jikoni, nobody talks about this mpishi in the kitchen, what they do. So there's so much behind the scene, really, who sometimes end up becoming scapegoats for either failures and sometimes unsung heroes of success. So they're always in that particular space. But I thank you so much for bringing this out, because I work in the area of healing, healing first before we discuss anything. Let's discuss healing, because even when we have the whole process and we don't talk about healing, then it becomes difficult into really getting the people out of the scenario. Thank you so much.
Thank you, Francis.
Thank you.
And actually, what I'm hearing you say is that, or what I can get from your sharing, Francis, is that you're already opening that space. I mean, that part of it, that's why this is supposed to be shared widely. Sorry, this is why these narratives, this is why this public awareness is important, because you never know how much healing or how much you can be part of a healing process of somebody. It's just kind of being open to engaging and listening. You never know who is your neighbor. You don't know who is your co-worker. You don't know what they're going through. Sometimes practicing empathy, even when we don't know what is happening with the person, it's I would say it's not something that always comes natural to human beings. We're easy to judge. We're easy to just kind of have our own perception of a story, of a situation. But it's kind of stepping back and saying, you never know where this person is coming from. Even when you find a person acting weird or behaving weird, it's reminding us, let's take a step back and try to ask what could be the reason why this person is behaving this way. It's not easy. I'm not trying to say I do that all the time. But some of this awareness is just trying to tell us, when you see your neighbor, your friend, a teacher, whatever profession, in fact, they might be. Of course, definitely today we were discussing frontline workers, but just trying to say, whoever that you come across, family and everybody, it's a good practice to, kind of step back to ask ourselves, how can I be more empathetic in any situation. How can I be nice? Be nice is a word that children use. Be nice. How can we try to practice that all the time? We are over time by 13 minutes. I know it's very late for most of you. If you can allow me to please give Eliud a second to see any last remarks that he may have, and then we can close it here and hope to see you next time. But Eliud.
Thank you, Damaris. I think my closing remarks would be about today's talk or the experiment really focused on the narrative workers and frontline workers. But as we close the call, think about yourself, think about somebody in your family, think about the 4 of you in a room. We said 1 in 4. And so actually we are all vulnerable. This message is for all of us. Even if there was a frontline worker on the call, perhaps he works as a rescue individual firefighter. But when he goes to a supermarket, a store, he's not a professional there. So he becomes public, he becomes society. So he still needs to work on that. So this message is for all of us. And as Professor said, let's continue to take care of ourselves. Let's invest whichever way we can, and let's spread the message. It's a narrative we began, and let the conversation keep going. Thank you very much, and I'm also honored to have spoken to this diverse international audience. I really appreciate it. Thank you so much.
Thank you again, Eliud, for your time and for sharing this very wonderful research, or you call it a mini study with us. And everybody who has stayed until the end, we really want to thank you, and appreciate your time for being here this late for most people. And as I said, we have 2 more presentations coming before May. That's when the semester ends. I shared a link to the African Studies Center website. If you have time, please join us. You can sign up on there. And we know it's always not the best time, especially because we're engaging our international participants starting fall, that is September this year. We'll try to see if there's an earlier time that would work, because either way, a time like this might not be working for our students, our faculty as well. But we're trying to navigate to see how we can accommodate all participants that are supposed to be participating at the African Tea Time program. But again, thank you so much for coming, and we hope to continue engaging in this conversation and many more to come. Thank you, everyone, and bye.